Hello, my name is Shay O'Brien. I'm a third-year pharmacy student at Drake University, and today I will be talking about cystic fibrosis-related diabetes. The objectives of this presentation are to understand the epidemiologic impact of cystic fibrosis in the United States and worldwide, have a basic understanding of the pathophysiology related to cystic fibrosis-related diabetes, recognize the common signs and symptoms of cystic fibrosis-related diabetes, and understand diagnosis requirements, identify the primary treatment goals and recommend appropriate therapy, and understand the role of pharmacists in cystic fibrosis-related diabetes management and patient support. We will go through the epidemiology, background, diagnosis, and treatment of the disease. And we'll start with the epidemiology. The estimated prevalence of CF worldwide is 1 in 2,500 live births, and in the United States, it is 1 in every 3,200 live births. The predicted survival has increased over the past 10 years from 30 to 41 years in the U.S. due to improved care and better diagnostic measures. However, the implications of an improved prognosis is an increased incidence of comorbidities such as CF diabetes, osteoporosis, and joint diseases. CF diabetes is the most common comorbid complication of cystic fibrosis, and more than 50% of cystic fibrosis patients will develop diabetes by 30 years of age. The typical onset is between 22 and 24 years of age. CF diabetes is associated with poor lung function, poor nutritional status, and a decreased prognosis compared to those cystic fibrosis patients without diabetes. We'll now move on to the pathophysiology of the disease. Cystic fibrosis is caused by an autosomal recessive mutation in the cystic fibrosis transmembrane conductase regulator gene, or CFTR. CFTR codes for an epithelial chloride ion channel, which is located in multiple organs throughout the body, such as the lungs, pancreas, and the GI tract. This mutation leads to impaired ionic balance of mucosal secretions, making them very thick. And the most severe feature of this disease is deteriorating lung function, which ultimately leads to respiratory failure. Cystic fibrosis diabetes has a slow, insidious onset and is characterized by a pro-inflammatory state and chronic pancreatitis. Beta cell destruction in this disease is multifactorial, but it does not seem to be from an autoimmune origin, as in type 1 diabetes, but rather the obstructive damage to the pancreas resulting from the thick mucus secretions. Contributing factors for the disease include chronic pancreatitis and fibrosis, low incretin levels due to malnutrition and malabsorption, and increased insulin clearance. Insulin deficiency due to pancreatic insufficiency is more often seen initially than insulin resistance. However, progressive insulin resistance does occur following chronic corticosteroid use, chronic inflammation, an acute infectious state, and hyperglycemia. Insulin resistance is also often seen during times of acute infections. We'll now move on to the diagnosis of the disease. For cystic fibrosis, the chief complaint is a chronic cough with thick sputum, salty skin, and recurrent respiratory symptoms and infections. Common manifestations include salty tasting skin, weight loss, infertility, digital clubbing, amenorrhea in females, infertility in males due to the absence of the vas deferens, and urinary incontinence. Typically, no parental history is present since it is an autosomal recessive mutation, and diagnosis is made when there is more than one clinical feature present, or cystic fibrosis in a sibling, or a positive newborn screen, in addition to evidence of an abnormality in the CFTR gene. The presentation of cystic fibrosis diabetes is characteristic of both type 1 and type 2 diabetes. There's a low incidence of ketoacidosis, a low incidence of hypertension and dyslipidemia, and obesity is not commonly seen. These patients are often malnourished, and there is no autoimmune component of the disease. Diagnosis of cystic fibrosis-related diabetes consists of an annual screening with an oral glucose tolerance test, which is recommended in all patients over 10 years of age. 2 consecutive positive oral glucose tests are required for diagnosis during a period of stable health. For the oral glucose tolerance test, it is required that the plasma glucose is greater than or equal to 200 milligrams per deciliter, a fasting plasma glucose greater than 126 milligrams per deciliter, and an A1C greater than 6.5%. However, A1C testing is not recommended for diagnosis because of fluctuations due to the chronic infections. We'll now move on to treatment. Cystic fibrosis treatment consists of 3 key areas: antibiotic therapy, airway clearance, and nutritional support. Antibiotic therapy is recommended both prophylactically and for acute infections. Chronic inhalation of tobramycin or azithromycin are often used for patients over 6 years of age, and chronic azithromycin is also used. For airway clearance, bronchodilators such as albuterol and ipratropium are used, and they have also been tested in combination. Mucolytic agents such as Dornase alpha and hypertonic saline are used, and corticosteroids for those patients who do not have asthma are not recommended. Chronic use of ibuprofen is recommended for patients 6 to 17 years of age with an FEV1 of greater than 60%. Various pulmonary rehabilitation strategies are also used. For nutritional support, a balanced high-calorie, high-fat diet is recommended with no specific restrictions, and pancreatic enzyme supplementation and also fat-soluble vitamin supplementation due to the malabsorption. For CF diabetes, the recommended therapy consists of individualized insulin regimens. No oral antihyperglycemic agents are currently recommended, and the CFF guidelines are followed for nutritional support. Moderate aerobic exercise is also recommended for at least 150 minutes per week to improve lung function. Plasma glucose goals are individualized per the patient, and monitoring parameters include self-monitoring of the blood glucose 3 times a day, annual monitoring for complications starting 5 years after the diagnosis, and an A1C is recommended quarterly with a goal of less than 7%. We'll now move on to the summary. Pharmacists' role in cystic fibrosis-related diabetes primarily entails patient education methods such as proper medication administration, timing, doses, side effects to look out for, hypoglycemia symptoms, prevention and treatment, including the proper use of glucagon, dietary recommendations as these patients are often malnourished, and lifestyle modifications. Pharmacists are also able to provide screenings to these patients such as blood pressure and lipids, and motivational counseling, as this is a very difficult disease to be living with for these patients. In summary, this is an autosomal recessive disease characterized by thick mucosal secretions and chronic infections. Cystic fibrosis diabetes is the most common comorbid condition of cystic fibrosis, and the current treatment guidelines recommend individualized insulin with no oral antihyperglycemic agents, and pharmacists play a key role in therapy management and patient education. Thank you for listening, and here are the references for the presentation.